Well, hello everyone. Thank you for joining us. This is Chadi Alraies, and this is Heart Trending webinar series. This is a new webinar series coming from the Facet, and this is focusing on interventional and invasive imaging webinars, coming in a series over the course of a year on every third Thursday of the month at 6 p.m. Eastern Time, 5 p.m. Central Time. We have a great kind of lineup of speakers coming this year, but we're going to open it up with my friend and colleague, Dr. Nazmi Calik. He is from Istanbul, interventional cardiologist. He had a great experience with a coronary intervention, complex coronary intervention. But this time we're going to focus on coronary bifurcation. This topic is very critical, has a lot of literature with different techniques, but also case-based illustration is very important. So with no further ado, Dr. Calik, thanks for being with us, and I will ask you please to share your screen.
Yeah, thank you so much, Chadi. Thank you so much for having me in this very interesting webinar series. And I wish you a success in your webinar series. I'm sure that it will be a very successful webinar series. And thank you so much again for having me. As you mentioned, coronary bifurcations are a very interesting topic of the interventional cardiology. So I think, to be honest, it's a good start for your webinar series. So can you see my screen right now?
Yes, perfect.
Yeah, perfect. So as you mentioned, we are going to start to discuss the bifurcation PCI. So as you can see my thread, we are going to start with the essential points to consider while just approaching a patient with a bifurcation coronary lesion. And then we are going to move on to the provisional strategy, and then T-tap stenting, culotte stenting, and I'm going to finish my presentation with DK crash stenting. Whenever you feel necessary, Chadi, please stop me, and we can just integrate some questions from the audience.
Absolutely.
Yeah.
And we encourage that from the audience. So throughout the webinar, please feel free to use the chat box and Q&A session function to throw.
Yeah, as you can see, Chadi, there are some essential points to consider while approaching a patient, an individual with coronary bifurcation lesion. First, we should understand the bifurcation anatomy, and then we should decide whether it is a true or false bifurcation, true or non-true bifurcation. We should address the reference vessel diameters. We should understand the plaque distribution and composition as well as the bifurcation angle. And then we have to understand whether this is a complex bifurcation or not, because this is going to affect our strategy. And then one of the major topics that I'm going to discuss is the side branch relevance. Is that side branch relevance or not? Probably this will lead some changes in our strategy while approaching a bifurcation lesion. So as you can see in this beautiful picture, a 3D OCT fly-through, the bifurcation anatomy, you see the bifurcation anatomy inside the vessel, and at each bifurcation site, you see a main vessel, a step down at the main vessel caliber. This is called main vessel caliber discrepancy. It is important to understand because when we are just selecting our stent while treating these bifurcation PCI patients, we always select our stent according to the distal vessel. As you can see here, there is a widely used FINET formula, which is D1 corresponds to the main vessel proximal, D2 is the main vessel distal, and the D3 is the side branch diameter. It is not this D1 that is not equal to the sum of D2 and D3. Instead, D1 equals to the multiply of the sum of the D2 and D3 diameter 3 with 0.67. So again, the Medina classification is a widely used technique, but it is not enough by itself. It tells us whether a bifurcation is true or not, or more simply, these bifurcation lesion includes a side branch ostial lesion or not, but by itself, the Medina classification is not enough to decide the correct bifurcation PCI strategy in these patients. So as I mentioned earlier, it's important to understand the reference vessel diameters. Of course, when we are selecting the stent to treat these bifurcation patients, we always select our stent diameter according to the main vessel diameter or to the side branch diameter. If we deploy our stent from the side branch to the main vessel proximal. When it comes to stent length, as you can see in the left-hand side, we have to consider our shortest NC non-compliant pot balloon because our stent in the proximal part of the main vessel should be long enough to cover our shortest pot balloon. And then you see the carina shift phenomenon here. If we select a larger stent, then it should be, let's say this vessel at the left-hand side is a 3.0 vessel, but if we deploy a 4.0 vessel, we should probably cause a carina shift, which may compromise the flow of the side branch. Of course, all stents are different. We have to know our stent platforms. You see the relation between the radio-opaque marker of these stents, the relation between the radio-opaque markers and the metallic scaffold of the stent. For example, in designs, the radio-opaque marker, the stent edge is at the end, in the middle of the radio-opaque marker, but when it comes to resolute onyx stent at the right-hand side, you can see that, you can appreciate that the radio-opaque, there is about 1 millimeter distance between the radio-opaque marker and the stent edge. This is important, particularly while we are trying to deploy our stents in a tap fashion or in osteal lesions.
That's a very important slide, actually.
Yeah.
The one before, especially with the landmarks, not everybody pay attention to, especially for positioning.
Yeah, so it's really important to understand our stent, which stent we use, and to recognize the stent we deploy, because it will probably lead, if we don't know the relation between the radio-opaque marker, the indicator at the end of the stent, and the metallic struts, probably we may lead a geographic miss at the side branch ostium. It is really important. And then another important aspect is the maximal stent expansion capacity, because as you can see, all the stent platforms are different in this aspect. And why this is important, you can see this from the simulation model that we currently do in our daily practice in my country. We have a course including simulation-based bifurcation PCI course using this wet model. As you can see, the distal part of the stent is 2.7, distal part of the side branch is 2.75. And if we apply the FINET formula in this patient, in this simulation model, let's say, the main vessel proximal corresponds to 3.5 millimeters. And our stent will be decided according to the side branch, but should be expanded safely in the main vessel proximal. You can see the malposition if we do not finish our strategy without proximal optimization technique, which we are going to discuss in the next slides.
Ali, just for the audience, the 275, you acquired this from IVUS imaging and to measure the side branch as well as the main vessel?
Particularly for this model, Chadi, it is in the instructions. The Stereo model, the wet model is sized according to the 2.75 in the main vessel distal, and according to the FINET formula, it is 3.5 in the main vessel proximal. So we used a 2.75 stent in the distal part while stenting this simulation model. Plaque distribution is another important thing to consider, Chadi, because as we know, at the bifurcation side, there is no plaque because there is a high shear stress. But when it comes to the opposite walls of the bifurcation, the carina, there is an increased plaque burden because of the low shear stress. It is always important to bear this in our mind. Let me show you with one example. As you can see in this case example, there is a plug extending from the RCA to the PLA. If we deploy a stent from the RCA to the PDA, of course, this plug will not vanish. We're gonna remove it from the main vessel to the side branch ostium. Understanding the plaque distribution is really important to anticipate where this plaque will go after we deploy our stent across the side branch. It is really important to predict this removal of the plaques. And then bifurcation angle is another important aspect to be evaluated before just putting our stents at the bifurcation site. As we know, in narrow angles are easy to rewire, but there is an increased risk of carina shift, and it is really difficult, challenging to cover the side branch ostium if we decide to deploy the second stent. Conversely, when it comes to the wide bifurcation angles, it is really challenging to rewire or wire these side branches with wide angles. But of course, as you can appreciate, there's a low risk of carina shift, and it is really easy to cover the side branch ostium with the second or with the first stent. This is a really important picture that I took from the JACC interventional. Each bifurcation site has to be evaluated in different angles, and we should find the optimum, the best angle to evaluate each bifurcation angle. For instance, for the LAD to diagonal, it is always good to assess these lesions from the slightly LAO to cranial. But when it comes to RCA, the PDA, and the PLA, again, a deep LAO and slightly cranial is the best angle to assess the side branch ostium. And then we have the definition criteria coming from the definition study. When it comes to left main stem lesion, the complexity means that you have to have one major and two minor criteria. What is the major criteria? In the left main lesions, your side branch, which is, of course, in the vast majority of patients, is the left circ, should have a severe stenosis more than 70% and more than 10 millimeters. And when it comes to non-left main lesions, the side branch stenosis should be more than 90%, and again, in the first, more than 10 millimeters. When it comes to minor criteria, the calcification, the thrombotic nature of the stenosis, multiple lesions, a narrow bifurcation angle, and the small main vessel reference diameter, and the long main branch lesions are defined as the minor criteria. And if a patient has a one major plus two minor criteria, this bifurcation is called complex bifurcation. When it comes to side branch relevance, there is a recent European Bifurcation Club consensus document on the side branch relevance, and it says a reference if the side branch reference vessel diameter is more than 2 millimeters, or if it represents a significant territory of the myocardium, it is called a relevant side branch. But it is always important to bear in mind that in the non-left main lesions, only 1 in 5 non-left main side branch supplies more than 10% of the total myocardial territory. Why these parameters are important, Chadi? Because assessing and, let's say, evaluating all these parameters should lead us for an optimal bifurcation stenting strategy in the index patient. Because I believe the most important part in the bifurcation PCI is not the putting the wires or doing the balloons or deploying the stents. I think the most critical, the most essential part is deciding for the optimal bifurcation stenting strategy. This is an algorithm which make my life easier at least while deciding a bifurcation strategy. My first question comes from whether this side branch needs to be preserved or not. If no, of course, we are going to stent the main vessel. But the second and the most important question is, what is the likelihood of the side branch occlusion if we deploy the first stent across the side branch? Of course, the parameters I mentioned in my previous slides, like severity of the side branch disease, location of the lesions, plaque distribution, lesion morphology, and bifurcation angle, plaque shift, and so on, are really important to consider. After considering all these parameters, if we feel that the likelihood of the side branch occlusion is low, we are going to move on to the provisional side branching strategy, which we are going to discuss in details in the next slides. As more focused on this provisional strategy, we first put our first stent across the side branch, and if we are not happy with the result, we can upgrade our strategy according to the angle of the bifurcation side. What if the likelihood of the side branch occlusion is high? Of course, in these patients, we should decide for an upfront, let's say, or dual upfront or systematic two-stent strategy. If there is major concerns regarding the side branch after main vessel stenting, we should secure the side branch first. And according to the angulation of the side branch, we can choose DK crash, inverted T or tap in the wide angles. But when it comes to narrow angles, the first option should be DK crash or inverted clot. Let's see in a more detailed slide. As you can see, if we have a major concern regarding the side branch, and if there is a significant diameter gap between side branch and main vessel proximal, of course, always we have to consider the stent expansion limits. If our stent will not expand from the side branch to the main vessel proximal safely, we should move on. We should go further with the DK crash and secure the side branch first. But if there are similar diameters between the side branch and main vessel distal, we can choose these techniques: inverted clot in patients in bifurcations narrower than 70 degrees, inverted T in 90-degree bifurcations, and if we have an angle between 70 or 90, we can proceed with inverted tap. And this is another beautiful central illustration, a review by Valeria Paradies and friends and colleagues. As you can see, this is a summary of what I mentioned in my previous slide. If there is a high risk of the side branch loss in the bifurcation PCI, which means there is a critical lesion in the side branch proximal, let's say longer than 10 millimeters, and in the intravascular imaging, if the plaque morphology contains calcium arc more than 60 degrees, we can consider two-stent strategy. Otherwise, we can proceed with a crossover stenting from main vessel proximal to the main vessel distal. And then we can assess the side branch flow after putting the first stent. If we lose the side branch flow, if the patient complains from the angina, or if there is some ECG changes in the cath lab, and if we see the flow compromise in the side branch, we can proceed, we can escalate our strategy into the two-stent strategy from the provisional strategy. And these slides are the summary of what I mentioned in my previous slide. It's a beautiful algorithm going from provisional to decay crash, particularly in the left main. As you can see in the left-hand side, there is a lesion extending from the left main proximal to LAD. But as you can appreciate, the side branch ostium, which is the left circ and the ramus intermedius here are clean. So we can apply a provisional strategy in this patient. But when it comes to the patient in the right-hand side, you can see a significant and a long, a calcific lesion in the extending from the left main to the LAD and the side branch. This is a complex bifurcation. So we should apply a DK crash, or let's say an pilot technique in this patient. I think it is really important to understand how to apply a specific technique according to the patient, Chadi. This is the
So Ali,
first
here
step.
in this, yeah, this is I think nice to pause here to kind of a lot of information came through.
Yeah.
One of the comments is, so you mentioned that this is for DK crush. It's advised for when you have a similar side of the distal main vessel. Here it's almost the same. It's a bifurcation lesion. And I think if you want to advise IVUS or any imaging tool wouldn't go
Mhm.
because of specific calcification. So this is kind of becoming more visual estimate of the visual side, and
Yeah,
that's to plan the technique.
of course. Of course. It is really important to understand because angiography has its own limitations while evaluating the calcium burden. Of course, it doesn't provide us with adequate information about
Mhm.
the calcium burden. Of course, if you have in your cath lab an intravascular imaging, of course, you should use it when if you are dealing with a left
Yeah,
main patient particularly. It will not only provide you with the vessel size, you can also assess your PCI result or the morphology of the plaque, whether it is calcific or thrombotic, or what is the burden of the calcium. But when it comes to deciding the optimal strategy in the patient in the right-hand side, yes, the circ and LAD, and geographically at least, seem
yeah,
similar. But when it comes to evidence-based medicine, of course, we have the data coming from the DK5 trial, which puts DK crash one step forward when it is compared with culotte technique, particularly in the left main bifurcation lesions, Chadi.
right, right. Perfect.
Yeah, for the sake of time, I want to continue with a stepwise layered provisional strategy. There are significant data coming from the Nordic BBC1, BBQ Cactus, and the EBC2. If we systematically put two stents in bifurcations, you increase, you may increase the all-cause mortality. And the data coming from the 10-year syntaxis trial, if a patient has a bifurcation, if a multivessel patient has a bifurcation lesion, the all-cause mortality increases. Again, furthermore, uh, if if you treat all the bifurcated lesions with two stents instead of one stent, again, you numerically increase the mortality. So
Mm,
this is really important. The recent
yeah,
evidence in 2023, recent evidence supported these findings, Chadi. The 5 years results of the EBC2 trial, which compared provisional strategy with culotte technique, systematic culotte stenting, showed no difference between two techniques when applied to the LAD, the diagonal, or let's say non-left main bifurcation PCI. As you can see, there is no difference after 5 years. And numerically, there are a decreased race of MACE with provisional strategy. This study tells us, as a summary, two stenting may not be beneficial for all the patients. And when it comes to left main stenting, again, in the previous year, in the Euro PCR, the 3-year results of the EBC main was concluded. And as you can see here at the right-hand side, if you apply a systematic dual stenting in all left main bifurcation lesions, you increase the revascularization rates when compared to provisional stenting strategy. And it is really important that in the provisional group, in these patients, only 1/5 of them needed a second stent. This is really important. This brings us a point that if we deploy all the left main lesion for all the left main lesions, a second stent in the circ ostium, you create a nidus for the upcoming major adverse cardiovascular events. And
yeah, so it's very so this is
yes,
so this is supports more. I think majority of the operator now go for provisional based on more recent data.
yeah,
But this is definitely very striking, especially with the 5 years follow-up.
yeah,
That's provisional really lasts
yeah,
as long as it's deployed and picked up for the right population.
yeah. So this brings us, Chadi, a point that for the cosmetic results, while dealing with the bifurcation lesions, of course, when we put the first stent from the main vessel proximal to main vessel distal, a crossover stenting, of course, let's say we see a suboptimal result, but an angiographically suboptimal result in the side branch ostium. That doesn't affect the flow or the FFR values. When the studies tell us that when you evaluate these side branches, the jailed side branches with FFR, you end up with putting less stents compared to the angiographic analysis. So this data tells us the same story. If you put the second stent only for cosmetic reasons, you increase the MACE. This is really simple. And of course, in our daily practice,
Mhm.
80% of the bifurcation PCI are now can be sorted out by provisional strategy, because provisional strategy is not a one stent or a two stent strategy. Provisional strategy is just something like that. If you need further steps that I'm going to mention in my further slide, you can upgrade your strategy to a second stent by deploying a second stent when necessary. So
Right.
let's go through the steps of the provisional stenting. Of course, the first step is putting the main vessel stent, which is sized according to the distal main vessel. And then the mandatory step is proximal optimization technique with an NC balloon sized according to the main vessel proximal. What if we miss? What if we skip this step? As you can see in the left-hand side, if you try to advance a third wire or
Yeah.
pull back your second wire just prior to the stent, you can easily go up luminal. So this will probably lead more and more problems to you in your cath lab. And of course, how to efficiently perform a pot at the distal coronal level, we should perform our pot. If we do it more distally, you can just cause a corona shift, as I mentioned in my previous slide. You can just over scratch your distal main vessel, or if you perform an imperfect balloon positioning proximally, probably you will lead an incomplete expansion at the side branch ostium. And you can also create a proximal stent edge dissection. So just while doing the pot, finding the most optimum angle is really pivotal. As you can see in this illustration, these are the first two mandatory steps of the provisional stenting, and then we can pause and then evaluate the result at the side branch. If you are not happy with the side branch flow, if it is compromised, as I mentioned, if the patient complains from the chest pain or the ECG changes, you can move on to the kissing balloon and repot steps. For this, you have to go through the distal wire. You should rewire to the side branch, as illustrated here. You pull back the main vessel, or you can use a third wire, guide wire, and you see we have to go through the distal strut, because it is important to go through the distal strut, because it will allow us, as shown in the right hand side of the picture, just it will remove the stent struts towards to the roof of the side branch ostium. It is really important for the further steps of the intervention of the procedure, Chadi. It is really important to go through the distal struts. Then,
and this is all just to guarantee the.
yeah,
Is there a certain shape of the wire for rewiring the
of course it is.
the distal part? Yeah.
Of course, it is important, Chadi. If we have challenges to the wire rewiring, of course, we have to give a second angle to the tip of the guide wire. So it will allow us to easily go through the distal thrust. It will direct us to the side branch through the distal struts. We have to give, this is, let's say, this is the first angle. We have to just put a second angle like this. And this distance should be same as the main vessel proximal diameter. If, let's say, if our main vessel proximal is 3O, from the second angle to the tip of the guide wire should be 3 millimeters. So it will allow you to go through the distal strut easily. So, and then we can just optimize the side branch ostium with the kissing balloon inflation, which is followed by repot, and then we can pause and evaluate the result again. As you can see here, these are the critical essential things to consider with the kissing balloon. Of course, it is recommended to do it with the non-compliant balloons, 1-to-1 sized according to the main vessel distal and the side branch. It is recommended to shortly overlap. If there is a longer proximal overlap, the repot is mandatory to correct the elliptical deformation in the main vessel proximal. It is recommended to sequential balloon inflation, side branch first, main vessel the second, and simultaneous deflation. And it is recommended to keep balloons inflated around 30 seconds. And
any sequence when you deflate the balloons?
It is recommended to simultaneously.
Go up together and go down together to operator or you and the technician. Yeah.
Of course, I think the most important part is the go down at the same time, deflate at the same time. As you can see here, the kissing balloon with or without repot. As I mentioned, Chadi, if you perform your kissing balloon inflation too proximal in the main vessel, you see the first balloon, which is colored with yellow, and the second with white. You see there is an elliptical deformation in the simulation model. And then one more important thing is the shrinkage of the stent just before the kissing balloons. You see here, there's a shrinkage of the stent at the edge of where the kissing balloons end. So I believe the repot, as you can see, this is after repot, the shape, the elliptical deformation is corrected, and this shrinkage at the edge of kissing balloons are corrected as well. And as you can see, there is a beautiful image, and the struts are open, which are going through the to the side branch. This is a case example, Chadi, for this for the steps until now. You see a 45-year-old female who presented with an ACS, and you can appreciate the LAD osteal lesion. And as you can, it's a focal lesion.
Yeah.
And geographically, we can appreciate that at the roof of the left main, the plaque extends to the left main. But it is always important to consider that even you cannot see the plaque extension from the LAD ostium to left main, and geographically, 90% of these lesions still extend to the left main. So it is really not recommended that to try to nail the ostium when you're trying to fix these lesions, particularly the osteal lesions. And as you can appreciate the IVUS run, because my suspect in this patient was whether this patient can be a type 3 spontaneous coronary artery dissection or not. I just put my IVUS run in, and as you can see, the atherosclerotic plaque extends from the left LAD to the left main. So we decided to continue with the crossover standing from the left main to the LAD. And then the second step is POT, which is mandatory. And the third, this is the at the left-hand side, this is the view after the POT. Then we rewired by pulling back the LAD wire and go through the distal strut. And then I parked the balloon in the main vessel, then advanced my second kissing balloon with the help of balloon anchoring in the main vessel. And then after kissing balloon, I did the final POT, and this is the final result. As you can
Wow.
As you can see, this is the IVUS run post PCI, which was really which revealed that the MSAs in the LAD ostium and the left main stent were good, were acceptable, and we ended up the procedure. So to summarize, the first step of this provisional stenting is the main vessel crossover stenting and POT. If you are not happy with the result, we can upgrade our strategy. And this is why this provisional stenting is now called stepwise layered. Because when you are not happy with the side branch result, you can put another layer and you can upgrade your strategy. The second layer is kissing, after rewiring, kissing and repot. And still, if you are not happy with the result, you can deploy your second stent according to the bifurcation angle. But it is always important to keep in mind that when you put the second step, the current data tell us you may increase the complexity and increase the risk of stent failure in the feature. So if you have any question at this point, or
No, it's perfect. I mean, this is a beautiful illustration, especially with the last case. Ali, you illustrated nicely that don't underestimate these are, especially with somebody with ACS, maybe it's thrombotic lesion, and always there's thrombus or plaque shift happen that compromise that's a large circumflex.
Completely right, Chadi. Completely right. So the bifurcation means if you decided to treat a patient with a bifurcation stenting, always put 2 guide wires. Always. This is the rule number 1. I see some cases in the current literature, they put the first stent from the left main to the LAD without a wire in the circ.
Right.
And when I asked the operator, why didn't you put the second guide wire? Because the circ ostium is wide enough. No, this is not a reasonable answer. Anything can happen. Yeah, a lifesaver. Yeah, anything happen during the bifurcation stent.
And in terms of guide size for these equipment, do you prefer 7 French or 6?
Theoretically, Chadi, you can just perform all of these stenting techniques that I mentioned in my
Hmm.
thread, T, tap, culotte, and DK crash with 6 French. But
Hmm.
to be honest, I always use if my procedure is elective, I always use 7 French,
Yeah.
which really makes my life easier and easier
Yeah.
because the quality of your equipment may not be always the optimum, you know. So 7 French
Correct.
is really makes my life more comfortable in these lesions.
Absolutely.
And uh, for the tap, probably one of the most common stenting techniques in our daily practice. As you can see, you can just apply it after the as an upgrade from the provisional strategy, as well as an inverted T or tap. If you think that you have a significant side branch osteostenosis, you can put your first stent from the main vessel to the side branch, and then you can just continue with the second stent. But it is really important to say that the tap technique or T technique is generally recommended for the wide angle bifurcations, wider than 70 degrees. This is a beautiful illustration of the tap stenting, Chadi. As you can see, the first stent is deployed. The 90% of the procedure is same with the provisional stenting strategy. As you can see, after pot rewiring, the first kissing, you can, if you're happy, you can stop. But if you're not, you can just continue with the second stent, as you can see in this illustration. T at and minimal protrusion to the main branch and the final pot. And
Beautiful.
what is the difference between the T standing and the tap standing? T standing is really difficult to apply because for a perfect T standing, you need a 90-degree bifurcation, which is not really common in our daily practice. So we always have to just protrude the second stand to the main vessel slightly. This is really important to know the difference between the T and tap. Basically, they are the same. But when it comes to final pot, as we protrude the second stand to the main vessel slightly, we have to perform the second pot, or let's say the final pot, just before the second stand. Otherwise, we are going to probably ruin the second stand ostium, and we are going to crush it towards the side branch ostium. So it is really important to keep in mind that we are going to protrude the second stand to the main vessel. So we are going to have a neocarina, as you can see in the right-hand side. So we have to keep this phenomenon in my mind while we are performing the final pot. And another important aspect is that I mentioned in the beginning of my presentation, the relation with the radio-opaque marker and the stent itself. It is really important to know your stent while you are trying to put your second stent in a tap fashion, because at the end of the day, you don't want to protrude your stent too much, but at the same time, you don't want to cause a geographic miss at the side branch ostium. So another important thing to consider is the final KBI during tap stenting. The name of the stenting technique is T and protrusion. You protrude your second stent to the main vessel. This is the neocarina. As I mentioned earlier, first the side branch, then the main vessel, but always deflate at the same time. If you deflate your side branch balloon earlier than the main
Crush it.
vessel, probably you will crush your neocarina to the side branch ostium, which will probably lead you a compromise in the side branch
Yes.
flow, Chadi. This is really important.
Yeah.
And this is a 72-year-old female presented with an anterior ST elevation myocardial infarction. And you see we just wired the both vessels after main vessel standing, of course, in an STMI presentation. You want to preserve the flow in the LED, which is completely understandable. And then you do a pot in the middle screen. And after rewiring, we optimize the side branch ostium. But at this time, inadvertently, the side
The wire is
branch
gone.
guide wire is gone. Just a
Oh my
nightmare.
God, that's
And
nightmare.
the side branch ostium is dissected after kissing.
Yes.
You see,
Yeah.
this is a true
Horrible.
nightmare. Yeah,
Nightmare.
and you know this always happen in the middle of the night.
Yes,
So
has to be.
yeah, and then hopefully we could manage to advance the guide wire to the side branch, and we parked a balloon to the main vessel and advanced the side branch stand of course because we have a dissection and a
Yeah.
compromised flow. We have to upgrade our strategy from the provisional to a second stand technique. So after putting the second stand, you see this is the carina, but we just protrude our second stand to the main vessel, so we have a neo carina in tap standing. So we do the final pot just above this neo carina, which is really critical in tap standing. So you see the
And
result at the end of
amazing.
the day.
Yeah.
You see,
And this
we
is
just,
very important. As you
yeah,
mentioned, the first slide is looking
yeah,
at the importance of the views
yeah,
and which vessel, because if your angles are off,
completely right.
then you
Yeah,
don't know where is the carina and where to
yeah,
land this tip tap.
yeah. You are completely right. And as you can see, as you can appreciate, this is the LAO cranial view.
Yeah, absolutely.
In Turkey, we call it 30-30 because LAO Turkey 30, cranial 30.
30, yeah.
Probably it is the same in United States.
Yeah,
This
always.
is
Yeah.
the LAO cranial is the best angle to evaluate this diagonal ostium because they really get how can I say bifurcated and you
Yeah,
see it beautifully the side branch ostium.
that's a good
So
save.
yeah, that was a good save. Thank you so much. Close standing, which is one of my favorite standing techniques, are really important because it's a flexible technique at the end of the day. As it is slightly different from the tap because in culotte technique, we need a narrow angle and similar sized side branch and main vessel distal. Because when you put your stand from the side branch to the main vessel, you don't protrude it minimally as in the tap. You just withdraw it to the main vessel with an overlap with the first stand at least 3 to 4 millimeters. So this stand in culotte the second stand should touch to the both how can I say both walls of the main vessel. So what I'm trying to say is both stands which are deployed to the main vessel and side branch should expand safely in the main vessel. This is the rule number one in the cloth stenting. As I mentioned, for the cloth is recommended for the narrow angles, narrower than 70 degrees, and both stents should be safely expanded in the main vessel proximal. Again, we are coming to a point that we have to know our
Mhm.
stance expansion limits. And we should minimize the overlap. This is another rule for the culotte. And it is always recommended to put the first stand in the angulated branch. This is another recommendation for the culotte standing. You see the steps, the first stand, first pot, first rewire, then second stand, second pot. It is really easy. In bifurcation PCI, each stand is followed by a pot. And then second rewiring, final kiss, and final pot. But there are some recent developments for the culotte stenting, which is first we now call it mini culotte because we are trying to minimize the overlap, which is called mini culotte. And second and more important thing is we are calling it now DK, the double kissing culotte. This is why
Mhm.
Gabor Todd and friends just showed that in a simulation model. as you see, we deployed the first stent going to the right, and without kissing balloon inflation, if you put the second stent, it may deformate the first stent. You see, probably this will bring you some difficulties in the second rewiring and the second pot. Instead, after putting the first stent, it is now recommended to perform a kissing, which allows you a better opposition, and then we put the second stent. So
Yeah.
we prevented deformation of the first stent, and to be honest, I apply this to my daily practice. So now we call it, as I mentioned, DK mini clot, and we have to perform a kiss before putting the second stent. So as you see, my Pokemon love in the slide, everything is getting, is getting some evolution. There was a conventional clot, and then it became mini clot, and now it is called DK mini clot. And this is a 70-year-old the male, who presented with unstable angina pectoris. You can appreciate a significant stenosis in the proximal RCA, and then a very high takeoff, probably the right ventricle branch, and there is a Medina 111 bifurcation lesions with a narrow angle. So after predilating and preparing each lesion, we first stented by covering the proximal stenosis to the more angled branch, the first stent. And then, of course, the first pot is mandatory.
Yeah.
After the first pot, you see there is still a significant stenosis in the side branch. Then the first rewiring from the distal struts again, you see. Then this is the first kissing balloon inflation, which stands for DK mini clot. And you see the second stent, Chadi. There is a minimal overlap around 3 to 4 millimeters. Then the second pot, then the second rewiring, again through the distal struts, and the second kissing. And after final pot, you see the result. And the patient is still doing fine. Of course, clot, there are some advantages of clot, which can be defined as this is a flexible technique. You can easily select the first treated branch, either side branch or main vessel distal. It ensures the full coverage of the main vessel proximal, distal, and side branch. There is no geographic miss. There's no risk of geographic miss as in the T and protrusion. There is minimal and no neocorvina, but when it comes to disadvantages, it's a complex technique, and it is necessary to perform 3 times pot, 2 rewiring, and 2 kissing balloon inflations. And there is still a double layer in the main vessel proximal. These are the Achilles heels of the clot technique. Oh, of course, we can pause if you want before going through the DK crash.
I think for the sake of time, maybe we should carry on with DK crush and
yeah, of course.
Yeah.
So as I mentioned in my first slide, Chadi, if we have really concerns about the side branch ostium, we have to secure the side branch ostium first. And again, let's go back to what I said in clot. If there is a significant diameter gap between your main vessel and the side branch, this means that you are not going to be able to perform a culotte tape or an inverted tap, because when you extend your stent to the side branch, you have to size it according to the side branch, right? But if you have a significant diameter gap between the side branch and the main vessel, you will not be able to safely expand this stent in the main vessel proximal. Probably it will hang with a significant malapposition. Of course, this is not recommended. In such patients, we have to apply DK crash. So when I go through the steps, I will not bother you. So I will fragment it. I will dissect it for you. The first step is parking a balloon in the main vessel then advancing the side branch stent and deploy. Then we have to flare the ostium of the side branch. This is a really important point, which will allow a better and a more adequate crush. Of course, always flare the ostium of the side branch stent at least 20 ATMs. Then it is time to crush. But again, there is one more development in while crushing. For the last 2 years, it is recommended to perform the crush in 2 steps. The first is a classical crush, as you can see, with a balloon sized according to the main vessel distal. This is what we do with what we always did. But now we have to add the pod crush, which is done with a balloon sized according to the main vessel proximal. Why this is important? After you stent your side branch and pull it to the main vessel, of course, because we are going to crush it. If you do the crush with a balloon sized to the main vessel distal, this is what you get, an incomplete and inadequate crush. Probably that will lead you some rewiring or rewiring issues or advancing the gear issues in your next steps. So now it is we always have to integrate this second crush, which is called pod crush. Okay, this is really important, and this balloon should be sized according to the main vessel proximal, which is called pod crush. Then, after crushing the stent, we remove the side branch. I know that Emmanuel Berlakis doesn't take this out. I had a chance to discuss this with him. And some operators, some giants really do not withdraw the side branch guide wire while putting the main vessel stent. After putting the main vessel stent, of course, it is followed by pod. Then now comes the difference from other techniques. We have to rewire from the non-distal struts. This is one of the rules of DK crush. Then we are ready for the kissing balloon inflation to centralize the carina in the step 10. And after this point, we finish our strategy with a final, let's say, repot. Let me show you my last case, which is a 61-year-old male, hyperlipidemic and smoking, admitted with unstable angina pectoris. You can appreciate that, Chadi, there's a significant lesion extending from the main vessel proximal to the distal. And you see the side branch, which is really long enough, which is a relevant side branch, going through the apicolateral wall of the left ventricle. Of course, after predilatation, I did this case 2.5 years ago or 3 years ago, let's say. Then I parked my crush balloon and the stent to the side branch. Then after putting the stent, it is really important to give a small amount of contrast before crushing, because you may lead a distal edge dissection. And if you cannot notice this and crush your stent without a wire in it, probably you will have some issues. So before crushing, it is always good to give a small amount of contrast to see there is no dissection in the side branch. Then it is time for a crush. But as you can see here, I did not perform a pod crush. I did only a classic crush without a pod crush. This is my self-criticism. Then we did a non-distal strut rewiring, which is followed by first kissing balloon inflation. Then it is time for the first stent, the main vessel stent, which is followed by pod. And again, we rewired from the non-distal strut again, the second kissing balloon inflation, as you can see. And after final pod, this is the result. And again, I did this case 3 years ago, and the patient is still doing fine. We still see each other in 6 months, or let's say 8 months. And this was
Beautiful.
last case. Two slides with the to compare the DK crash or the provisional. As we know, the Chinese giants are the producer, are the inventors of the DK crash. So they have the DK crash 5 trial. And the European, as we are much more doing the same with the European, there is the EBC main. But there are significant differences between these two trials. Both trials compared the provisional strategy with systematic two-stent strategy. But as you see, the patients in DK Crash 5 trial have more significant side branch ostial stenosis length, which is 16 millimeters. And these two trials are conducted for left main lesions. So it means there's a significant, at least 16 millimeters lesion in the circ ostium. But when it comes to EBC main, this is 7 millimeters. And this is a significant difference. Then, in the provisional arm, only 1/5 of the patients upgraded to a two-stent strategy from the provisional strategy in EBC main trial. But when it comes to DK Crash 5, the provisional arm had to be upgraded. Well, half of them had to be upgraded to a two-stent strategy. This means the DK Crash 5 participants had more severe coronary bifurcation lesions. And of course, in DK Crash 5, the systematic two-stent strategy was DK Crash. But in the EBC main, as in the European practice, daily practice, half of the patients received culottes, and one third of the patients received T or TED. These are really significant differences. And this is one of my favorite slides about the DK Crash 5 trial. As you can see, there are two subgroups, which is complex and the simple lesion participants. And in the complex part, you see the left circ ostium stenosis length. It is around 16.7 millimeters. Of course, if you apply a provisional strategy in these patients, the results will not be so good because you have a 16 millimeter side branch ostial stenosis, which will cause a significant maze in the feature. So, but when it comes to subgroup of simple lesions of the DK Crash 5 trial, there is not a significant difference between the provisional and the DK Crash. But in the complex lesions, there is a significant difference between the provisional and the DK Crash stenting when it comes with regards to 1 year target lesion failure. So my take from these two trials are, if a left main lesion or a non-left main lesion have a significant side branch ostial stenosis, of course, the DK Crash may be a better choice than provisional strategy. So DK Crash has significant advantages, like, as I said, preferred in cases with significant main vessel to side branch diameter gap. Ostium is adequately covered. There is no geographic miss. Very low risk of side branch loss throughout the procedure. And to me, the most securing part is your main vessel is always wired throughout the procedure. You don't take this wire out or in. But of course, it really necessitates a significant operator experience. You have a triple layer stent in the main vessel. It's complex, time consuming, and the operator experience is really important when it comes to DK Crash. Chadi, thank you so much for having me, and this is all from my side, at least for now.
Thank you. Thank you so much, Ali, for a really wonderful insight and presentation. I mean, this is a textbook in 1 hour kind of illustration of the bifurcation stenting. I have one question before the end. Is in terms, we didn't speak about too much of the wiring and which wire you use to recross, especially if you have a preferred wire or recommended wire for recrossing, especially if you have too many layers of struts and
Of course.
to engage and to cross the distal part of the side branch.
Of course, I do around 80% of my cases with my workers guide wire, which is a choice floppy. But when it comes to challenges to the side branch, to crossing the side branch osteum, which is really calcified, of course, I choose hydrophilic wires. Hydrophilic wires. But we need to always be really, really careful with the hydrophilic wires because they can easily go through the dissected lines, particularly. So yes, my first choice is my workhorse. My second choice in challenging anatomy is the calcified anatomies is the hydrophilic guide wires.
Awesome. Perfect. Thank you so much again. Well, I mean, this is a wonderful illustration of the bifurcation stenting. Really enjoyed your presentation dearly. Thanks for everybody for joining us. We went a little bit above the hour. I just want to highlight a few things for coming webinars. Next webinar going to be March 21st. And our guest is going to be the Chief Cardiology at Mayo Clinic about coronary complication and management, Dr. Rajiv Gulati, followed by Director of Research at the University of Cincinnati, Dr. Tim Henry, talking about the contemporary management of hospital cardiac arrest. And also for May, we have Dr. Bill Lombardi talking about resilience to burnout. And he's coming to us from the University of Washington. With that, I would like to thank Dr. Ali for his time and commitment, as well as for waking up at 2 o'clock in the morning Istanbul time. And now it's 3 o'clock, 3:09 for your time. And hopefully we can have you again.
Yeah, of course, definitely it worth it. Definitely it worth it. Many thanks for the invitation. I really enjoyed I didn't understand how 1 hour passed, to be honest. When I looked my watch, it was just, we are already 10 minutes late. Thank you so much for
having me. I think your passion is coming across and your hard work, definitely, and your knowledge of the topic. Thank you for all the audience. We'll see you next month. Thank you for watching us. This is Chadi Alraies from Heart Trending.